Is my screen visible now? Is my screen visible?
Sorry.
Good evening, Dr. Mohanjit, ma'am. Good evening, Dr. Harpreet.
Good evening, sir.
How are you?
I'm fine. How are you?
Pretty good. Thank you very much. Screen, is the slide set moving? Can you just check if the slide set is moving?
Very much visible and I mean nicely.
Slide is visual, sir.
Moving as well. Can we move the slides? Is it gone to the second slide now? Arvindji, has the slide moved to the second slide, third slide?
Yeah. So slide is moving, sir.
Perfect. Thank you.
Yeah. So I think, sir, Dr. Mohanjit Kaur has joined, Harpreet Kaur has joined, sir, and Dr. Archan also has joined. Sir, wait for 2 minutes. I think other participant will also join, sir.
Good evening, Dr. Archan.
Thank you, sir.
I think you're muted, sir, Dr. Archan. Muted. JJ.
Good evening, sir.
Good evening. How are you?
I am fine. How are you, sir?
Very, very good. Thank you very much.
Nice to see you, sir, after a long time.
After a long time, yes. Post-COVID, yes. Great. All okay in Canada?
Yeah.
Great. Perfect.
How's your daughter doing?
She's doing well. Thank you. She's doing well.
So I think all the panelists has joined, sir.
Right.
So if you allow, sir, shall we start?
Yes, please. Why not?
Yeah, sir. So first of all, welcome, sir. I am Arvind, sir, regional sales head in Ludhiana, sir, and personally I welcome, sir, Dr. Sandeep Chopra, sir, DM cardiologist, sir, and additional director of cardiology Fortis, Ludhiana, sir. Welcome you, sir, for this scientific session, sir, and thanks for allowing us for this program.
Thank you.
And apart from this, sir, I also welcome our expert panelist, Dr. Mohanjit Kaur. Welcome, ma'am, and Harpreet Kaur, Dr. Atul Gupta, Dr. Hardeep Singh, and Dr. Archan Garg for this expert form program. So once again, personally welcome to all the delegates. And as you know, sir, this is a program based on so benefits of MRA in heart failure as early use, sir, the beneficial in a patient of heart failure. So, sir, welcome to all the delegates and Dr. Sandeep Chopra. And sir, over to you.
Right, thank you very much. Give me a sec. I think I'm having some network problems. I'm just changing my Wi-Fi network. Give me 1 minute.
Okay,
please.
Right, sir.
All right. Am I audible and visible now, Arvindji? Arvindji, am I audible and visible?
Yeah, sir. Yeah.
All right.
Yes, audible, sir.
Right. Good evening. Right. Good evening, friends.
Okay.
Good evening to all my colleagues. I think can we mute the other participants and we can switch them on whenever we're answering questions. All right. So we'll be talking about mineralocorticoid receptor antagonists, moon in heart failure management. Heart failure is the next big thing in cardiology, even with new oral hypoglycemic drugs, giving such a beneficial effects in heart failure. We all have known now with experience and time and studies that Heart failure is a disease with a very high morbidity and mortality, even worse than most cancers. But good for our patients that there are so many drugs coming in which are helping them and helping us in alleviate their symptoms. So the agenda will be it's just a brief question answer sessions with a major emphasis on the major pillar of heart failure management in the form of mineralocorticoid receptor antagonists. What is their placement and utilization in heart failure management? Hyperkalemia, is it really a concern in physician practice? And how do we create awareness amongst ourselves, our peers, amongst us for the use of these wonderful molecules? Before we proceed, we should all know the enormity of the problem that we are facing. The prevalence is 26 million people worldwide. 1 to 2% of the adult population with heart failure in developed countries. I'm sure more so in developing countries. Prevalence is increasing with age, rising to more than 10% among people more than 70 years of age. The problem in India is this happens 1 decade earlier. So our younger population, middle-aged population, in their peak of their careers are developing, or their peak of their productive life are developing heart failure. And looking at this disease with such a high mortality and morbidity, that is a major cause of concern. 1% of the total population, or about 8 to 10 million individuals have heart failure in India. The annual incidence being 0.5 to 1.8 million new cases per year, and mortality being very significant as well. The difference in heart failure in India and overseas is a higher mortality compared to the Western world, maybe partly because of our fault. We are not giving the best to our patients, a lot so being with the cost factor and the difficulty in our patients to accept standard treatment. Secondly, the etiology, a lot of rheumatic heart disease, especially amongst the lower socioeconomic strata. So lesser younger age group and higher mortality is what our major concern is in heart failure in the Indian subcontinent. So let's open this discussion with a very simple question. What percentage of heart failure patients approach you in NYHA class 2, 3, 4? And how many heart failure patients go undiagnosed in India at an early stage, and why? So we'll open this discussion to all of us, and anybody wants to take this. So what percentage of heart failure? So out of all the heart failure patients who come to you, how many will be in class 2, class 3, and class 4 in your clinical practice?
Sir, lately we've been seeing patients I have seen patients who just walk into your OPD with just little shortness of breath on exertion.
Yes.
And
yes.
if you just question them, and that to leading questions,
yes,
only then they are able to tell that they have swelling in the feet, they have other symptoms, and if you get an echo done, you see the EF is on the lower side.
Sure.
So there are patients who just come with very little symptoms also.
Yes.
But majority generally do present in the emergency with orthopnea and definitely class 3 NYHA.
Perfect. So I would say a lot of patients, like you said, are more than class 2, but if you delve into the history very carefully.
Yes,
true. That's absolutely correct. If you go deep into the history, a person might be walking for 5 kilometers every day, and suddenly he starts walking 2 kilometers every day, and not realizing that his exercise capacity is coming down. Yes. So that is also heart failure. Very true.
A day before yesterday, I saw a patient in the OPD. He just came to me with shortness of breath for 4-5 days, and that too only on exertion.
Sure.
I just asked him a question: do you get swelling in feet? Yes, when I travel so much, I get swelling in the feet. And I got an echo done. His EF was just 25%.
Yes. Very nice.
He had no other complaints at all.
Yes. So I think echo is a very simple investigation. Like we've aggressively used ultrasounds in the past, and echo should be more and more used to diagnose. His
ECG also was not showing much of the changes.
Sure.
Just LVH. So it just clicked that I should get an echo done to see what things are going on, and his EF was just 22%.
Right. And how many heart failure go undiagnosed in India at an early stage, and why? So I think
if such kind of a patient comes to the OPD and if echo is not done, there would be so many patients who get missed.
I'm sure. Yes. So like we said, echo and
can also try to hide their symptoms, particularly elderly people.
Yes.
Who are around 60 or 70, they try to avoid telling the symptoms what they are going through.
Yes. Right. So and I think it is our duty to to convince them and convince them about a simple X-ray which might just show cardiomegaly. I get a lot of referrals now. X-ray being screened for breathing difficulty, which is an excellent tool, but echo should be used much more aggressively and rampantly to diagnose a simple cardiomyopathy.
Sorry to interrupt. I think young patients should be more screened vigorously because they won't tell. They would say कि yeah, we are fit. क्या हो गया कि 5 किलोमीटर से 2 किलोमीटर हो गया, कुछ नहीं होता, कुछ हो गया होएगा, weakness आ गई होएगी. Because those patients who are 40 to 50 years of age, they will definitely get missed. A 70-year-old person, if he has shortness of breath, he might tell कि मेरे को problem हो रही है. His daughters or son definitely would take care. But a young patient, in my opinion, has to be screened vigorously because they won't tell. They will just say कि हाँ weakness होगी, हमें क्या होगा.
There's a fear of getting diagnosed with a major condition.
They would definitely say कि इतनी young उम्र है, अभी हमें क्या होगा.
Yes.
So that's one thing which gets missed, and sometimes this also leads to sudden cardiac deaths.
Yes.
Young patients we are seeing now, young people who are we do listen, but I think they should be more vigilant. I think they should be taught to be more vigilant nowadays because the lifestyle is different. They are not exercising much.
Yes.
I think young patients above 40, vigilance should be more.
Yes. And if you Dr. Harpreet, if you don't mind going to the second question, if such a patient comes to you, what are the diagnostic and prognostic tools which you will routinely use in your patients to diagnose them and prognosticate them?
So I think in grade 2, echo would be one thing. X-ray is the basic thing.
Yes.
But if a patient lands up in the emergency, I think pro-BNP is one thing which has to be done to rule out if it is a cardiac issue and to differentiate between the other things also.
Yes.
And obviously echo, if bedside is available in an emergency, it should be done. Prognosis also, I think follow-up echoes, I will not say very regularly, but at least once in 6 months.
Yes. So NT-proBNP being the cardiac biomarker of choice for diagnostic and prognostic.
Heart failure, yes, definitely.
Yes.
Dr. ECG will be useful.
Sorry, Dr. Archon, you were saying something?
ECG will be useful to see for any arrhythmias
and acute coronary syndrome, yes. So acute coronary syndrome and arrhythmias, ECG will be a very important marker, even more important than an echo. So both are equally important. Monjit ma'am, you were saying something.
Yeah,
sorry.
Actually, I just want one clarification, Dr. Sandeep. See, the thing is, as far as the diagnostic and prognostic tools are concerned in clinical practice. See, if we talk about heart failure with reduced ejection fraction, of course, bedside echo, or otherwise also echo is quite, important tool. And I think this is the one, the only reliable tool. But what about the patients with heart failure with preserved ejection fraction?
Sure.
So what about those patients and prognostic tools other than BNP and the cardiac markers in these patients? So how do you assess these patients clinically as far as prognosis is concerned?
Great. So there are three differentiating points. The classification of heart failure is in 3 divisions now. Heart failure with reduced EF, like you rightly said, and there's heart failure with mid-range EF between 40 and 50, and above 50, mid-range EF and or a moderately reduced EF, and then there's a heart failure with preserved EF. So what we are targeting here is a HFpEF, HFpEF, or a heart failure with preserved EF. So yes, the cardiac biomarkers that Dr. Harpreet ma'am correctly mentioned now, NT-proBNP holds true in heart failure across all categories. But in heart failure with preserved EF, when you have a ejection fraction being documented to be normal, most of the HFpEF patients have a precipitating factor, and that is what you're supposed to treat, like accelerated hypertension, any arrhythmia like atrial fibrillation, any coronary artery disease or active ischemia. So those are the precipitating factors of HFpEF. So target those in HFpEF and treat the HFrEF with the standard of care.
Yes, definitely. You are absolutely right, Dr. Sandeep, because in all the studies and registry studies which have been done, acute coronary syndrome is one of the most important. If you see the studies, like, I mean, the regional, there was such a big study. I'm sure, I mean, you must be having more expertise in that. Registry study was done about the regional differentiations as far as the precipitating factor for heart failure are concerned. So acute coronary syndrome was the most important factor. Sure. So prognostic tools, I was saying,
prognostic tools, again, NT-proBNP remains the most important prognostic tool for heart failure. But when you talk about cardiac biomarkers, there's a soluble ST which you're not using, and there's the normal cardiac biomarker troponin T levels. That is a sign of acute prognostication for heart failure as well, not just for acute coronary syndrome, because it shows myocardial damage.
Okay.
So in the case of preserved ejection fraction,
yes,
can diastolic dysfunction plays a culprit? Maybe
absolutely.
Culprit?
So being precipitated, being precipitated by tachycardia like AF, being precipitated by acute coronary syndrome, ischemia. So those are precipitating factors. Without a reduction in the ejection fraction, the patient still goes into heart failure. I'm sure all of you see a lot of patients who come with acute onset breathlessness with a EF with a BP of 200 by 120. Yes. So that's HFpEF, and it's just not accelerated hypertension causing the breathlessness, but basically heart failure in spite of the ejection fraction being normal.
Actually, that is the reason. Actually, now more and more emphasis is on the diastolic function of the heart. It is not considered a mere conduit.
Yes, true.
For the blood being pumped into it, but it has an important pathophysiological emphasis as far as the heart failure is concerned. Yes, definitely, Dr. Archan.
Sure.
Yeah.
Sir, I have a question.
Yes, please.
You told about TROP-T being a prognostic tool.
Mm-hmm.
How often do we use it in patients who are asymptomatic, on follow-up patients, or who are just having class 1 or class 2 symptoms again?
So troponin is only meant for acute decompensated heart failure who comes to your ICU, not for an OPD patient.
Na?
Yes.
ICU patient, not in OPD.
Not at all in the OPD.
Not regularly, not in OPD basis. Only those patients who have come with grade ADHF. 3 or grade 4 in the ER.
ADHF, acute decompensated heart failure. Yes, that's all. Yes, not on an OPD basis. And I would say, NT-proBNP, theoretically, we all know it's such an important tool. People have started using it, but I think it's
not on OPD basis.
But we are not using it routinely because it's an expensive investigation. It's not going to change your treatment because you have an ejection fraction. You have a good
patient is asymptomatic, then there is no test has to be done, and only the treatment protocol has to be done.
Yes, absolutely. Yes, please.
The thing, once the decompensation occurs, then the whole cascade of pathophysiological changes like plasma renin and BNP and everything starts getting in. So that is the reason it has more value when the patient lands up in acute decompensation, because then the whole cascade.
Yes. But even Dr. Mohanjit ma'am, even with class 2 symptoms, the patient might have a raised NT-proBNP. You don't have to have a total acute decompensation of heart failure. Even with early heart failure symptoms, patients' NT-proBNP will start rising.
Yeah. Okay.
All right, we move on. Okay, so we're coming to the crux of our talk today. So we are talking about mineralocorticoid receptor antagonists, namely spironolactone and eplerenone. We all are scared to use them, though we know that they are in the recommendations because we as doctors are scared about hyperkalemia, renal decompensation. So caution should be exercised before we start our questionnaire. Caution should be exercised when MRAs are used in serum potassium more than 5 or severe renal impairment. So are these parameters, potassium, creatinine, eGFR, tested before and after initiating MRAs, and how long? So what is your experience with these drugs? a patient comes to you, I'll go straight to the trade name. Do you use Ditor or do you use Ditor Plus? It's a Ciplatox.
So I prefer, sir, if a patient comes to me, on an OPD basis and just has class 2 NYHA, I would prefer starting first that patient on an MRA, then going on to a combination of both Ditor as well as the Spironolactone. But my first preference always has been an MRA along with other cascade. But in a patient who is class 4 or who has come with an acute decomposition, I think a combination has to be used.
Fantastic.
But first drug, a diuretic, if I have to use, I don't switch on first to the diuretic, but I go more for an MRA. And according to the potassium monitoring, if the potassium comes out to be 5.4 in the next visit, I might add on a little diuretic and a combination of both.
A loop diuretic, yes.
A loop diuretic, basically, to just control that, because loop diuretic will decrease the potassium, but MRA would increase the potassium. So there has to be maintained a balance also. And also it will help the patient in the symptoms.
So would you check these parameters?
But my first preference has always been Aldectone.
Right. Would you check these parameters before initiating your drugs? Do we
Yeah,
get a
definitely, sir. Definitely.
Right.
Always.
Dr. Archan, please.
Yeah. Particularly if we are using along with ACE inhibitors or ARVs, I think we should be more careful about the potassium level.
Yes.
And also if the baseline creatinine is like around 1.4 or 1.5, we have to be more cautious.
True. Do we have other panelists with us? Dr. Atul, please, if you want to give your input, sir. Dr. Atul, Dr. Vinay.
Sir, how about hyponatremia in such patients?
Dr.
Hardeep.
Yes, Dr. Hardeep. Hi, good evening to you. Hyponatremia. The hyponatremia is more of a problem with our loop diuretics. So yes, we will get a baseline sodium, potassium, and creatinine levels. So what we normally follow is get a baseline RFT along with the routine investigations. And Dr. Harpreet has mentioned earlier, always initiate the patient on an MRA first, especially if the patient is in class 1 to 2 heart failure. And loop diuretics, because loop diuretics do not have a mortality benefit. The mortality benefit comes only with the MRAs. So any experience with Eplerenone in our panelists, please?
Sir, I have more used Aldectone, less of Eplerenone. But yes, a patient who comes to me who's already taking an Eplerenone, I don't change it. So I have been more I have been using more of Aldectone.
Yes, so it's cheap, it's easily available, it's accessible to our population.
Yeah,
and it has a mortality benefit.
It is antifibrotic, so it definitely has a role in cardiac remodeling. So I prefer Aldectone.
Right. Dr. Mohanjit, ma'am?
Yeah, very true. Actually, as far as the diuretic part is concerned, these drugs are they come to the category of weak diuretic. But yes, definitely, as far as the other benefit of blocking the aldosterone is concerned, like the myocardial remodeling, and as Harpreet has very clearly mentioned, so in that thing, they definitely reduce hospitalization, reduce mortality, and improve quality of life. So these are actually preferred drugs. So as far as the class benefit is concerned, of course, I think the patient profile is very, very important, because as far as the high aldosterone effect is concerned, there is not much difference. But then there are other factors also, cost and in the hormonal effects and gynecomastia and other other things are concerned. So there we have to take the choice.
So yes, a point very, very aptly mentioned by Dr. Mohanjit, gynecomastia. And gynecomastia, if you look carefully, it's a very common side effect of spironolactone. A lot of patients come to us with chest pain, and if you ask specifically, they would say it's tender around the breasts. So gynecomastia is a very common point, and we might have to discontinue our drug because of this.
Then
so yes, cost factor with the Eplerenone, yes.
I think as far as efficacy is concerned, it's both are same. If we compare spironolactone and Eplerenone, but side effect profile is better with the Eplerenone, so we should prefer, I think, second generation with the MRA.
So, Dr. Achan, the side effect profile is less, but I would humbly say that the efficacy is also slightly more, and the mortality benefit with the Ephesus trial, which came with the eplerenone, is more vis-a-vis spironolactone. So if cost is not a concern, we should prefer eplerenone, but cost is a major concern in 70–80% of our patients here. So obviously, instead of not giving anything at all, spironolactone should be our first choice anyway.
Depending on the patient, we can decide.
Yes, according to the financial status of the patient. So the mortality difference is not very significantly high that I would like to put eplerenone on everybody. Spironolactone is a wonderful drug. Dr. Harpreet initially mentioned that you can add dietol to offset the effects of potassium levels, but in class 1 and class 2 the patients, you do not need to give torsemide or furosemide. So prefer to increase the dose of spironolactone or eplerenone to 25 to 50 mg rather than adding a loop diuretic, and add that only if the patient becomes symptomatic. Any other inputs, please? Dr. Vinay?
I would say the other part of the question is, after initiating MRAs, how often we test for this potassium levels and creatinine. Nobody said about these things, but I have a habit of checking these levels every visits, mostly after initiating, firstly after 1 week, and afterwards 15 days, and then monthly. I used to check these because potassium levels is one thing you cannot ignore in these chronic patients.
Yes, especially with heart failure, the patient will also be on an ACE inhibitor or an ARB or on ARNI. So yes, hyperkalemia is a major concern, and we have to be careful about that. Point well taken. Any other inputs on this parameter? Okay. So heart failure guideline recommendations for MRAs. European Society of Cardiology mentions that for HFrEF, that's heart failure with reduced EF, MRA is recommended to reduce the risk of heart failure, hospitalization, and death. It is a class 1 recommendation. So we all senior physicians of the town, we have to educate our colleagues that simple torsemide is not enough for heart failure. You haven't done enough for your patients if you have just alleviated the symptoms of breathlessness and pedal edema. You have to reduce the mortality of this, of this very aggressive disease by adding a very simple and a cheap drug available in the market, an MRA. So all our prescriptions should carry an MRA for all heart failure patients, especially with the reduced ejection fraction. So this is a summary of how we manage HFrEF. Beta blockers, MRAs, ARNI like sacubitril/valsartan combination, and most recently SGLT2 inhibitors. Beta blockers most specifically are carvedilol, bisoprolol, and long-acting metoprolol. So you can use only these 3 beta blockers in heart failure, not the short-acting Metolar or Betaloc, but Metolar XR or Seloken XL, bisoprolol, and carvedilol. Try and upgrade the dose to the maximal tolerated doses. MRAs, like we've mentioned, spironolactone and eplerenone, going up to the dose of starting with 25 once a day to 50 once a day. For eplerenone, you can go as high as 100 once a day. ARNI, that's sacubitril/valsartan, also known as Vimada very commonly. Starting dose is 50 BD, going up to 200 BD. That's available as Vimada, Azmada, and Sidmus by 3 major companies. So 50 BD over 4 to 6 weeks, you up titrate the dose. Again, looking at renal decompensation and hyperkalemia, especially used in combination with MRA, and SGLT2 inhibitors like dapagliflozin and empagliflozin. So irrespective of the presence or the absence of diabetes, SGLT2 inhibitors should be a part of all heart failure regimes. So all these 4 drugs are all pillars in the treatment of heart failure and should be there on every prescription unless contraindicated. So if there's volume overload, you go on to diuretics like loop diuretics. If the patient continues to be in tachycardia, that is sinus tachycardia with a heart rate of 70 beats per minute, in spite of the maximally tolerated dose of beta blockers, you add ivabradine, dose being 5 mg once a day to twice a day, to the maximum dose of 7.5 twice a day. These patients should be considered for a device therapy, that's a CRTD, that's cardiac resynchronization therapy with defibrillator, if the patient has a left bundle branch morphology. Simple drugs like Lenoxin, we've been using for the last 20-30 years, are still not out of vogue. You should add these in all your patients unless there is a contraindication. Will especially help if there is atrial fibrillation. It does not have a mortality benefit, but will have a morbidity benefit. If the patient continues to be in AF, you will like to add a oral anticoagulant. One thing we forget is simple things like exercise rehabilitation and a multi-professional disease management. My hospital also has a nurse educator and a follow-up patients in charge for all heart failure patients who are on ARNI. So these 4 drugs should be, in all our prescriptions unless contraindicated. So going on back to our practice here, in what percentage of patients would you use MRAs for heart failure management? Dr. Archand, sir, please.
Please come again.
In what percentage of patients would you use spironolactone or eplerenone for heart failure management?
I think in most of the patients, I would like to prefer MRAs unless there is some contraindication, like some renal failure or hyperkalemia.
Sure. Going to the second question, when do you start considering MRAs in patients with heart failure along with ACE inhibitors, ARBs, and beta blockers? Dr. Hardeep, if you'd like to take this, please. Or anybody from the panel, please. So yes, please.
With the first prescription itself, sir, should be added.
Yes, so MRAs, according to you, should be added in the first prescription of heart failure, and I would completely agree with you here. So always remember the 4 pillars of heart failure we've talked about: beta blockers, ACE inhibitors, ARBs or ARNI, SGLT2 inhibitors, and spironolactone. Try not to add all 4 together. You have to give it some time, 3 to 4 weeks, to adjust one after the other. So what is your choice? So which out of these 4 MRAs you said you'll add first on, what would you like to add along with MRA?
Beta blockers.
Excellent choice. And I think that should be the protocol. Beta blockers and MRAs should be your first choice for all heart failure. See how the patient responds, and then go on to ARNI and then to SGLT2 inhibitors. Some studies have come showing that beta blockers and SGLT2 inhibitors should be added up front. But my choice is, I would agree with Dr. Hardeep here, ARNI plus MRA, beta blockers plus MRA, and then ARNI, and then SGLT2 inhibitors. Anybody else wants to comment on this slide?
So what about ACE inhibitors and ARBs?
Dr. Vinay, sorry.
What about ACE inhibitors and ARBs?
Yes, so ACE inhibitors and ARBs.
It is not choice.
Yes, so ACE inhibitors and ARBs and ARNI come in the same category, ARNI being sacubitril valsartan. But yes, looking at our population, ARNI is very expensive, at least for 1 more year. So ACE inhibitors and ARBs remain the #1 choice along with beta blockers and MRAs, should be added as soon as possible. A point I'd like to mention here is, even I was, I've been learning about heart failure the last few years. In the ACE inhibitors, we all use ramipril post-MI because of the HOPE trial. And ramipril is the #1 choice for post-MI patients. But for any cardiomyopathy, the plain and simple enalapril is the drug of choice for heart failure with reduced TF, not ramipril. NVAS, the plain and simple NVAS we've been using since our training days, 2.5 BD. So use enalapril for your heart failure patients with reduced TF and not ramipril as your first choice. If you want to use ARBs instead of ACE inhibitors because of the presence of cough or your preference, valsartan, the valsartan plain, not ARNI, but valsartan plain remains the drug of choice, starting at a dose of 40 mg once a day or twice a day, go on to 160 twice a day, depending on your blood pressure and your renal dysfunction. So ACE inhibitors is enalapril, ARBs is valsartan, and then ARNI has overtaken them in terms of mortality benefit. Dr.
Yes,
Vinay, I hope that answers that.
So if the ejection fraction is less than 25%, should we go for beta blockers?
Yes, absolutely. No matter what the EF is, if the patient doesn't have a loud LVS3 gallop, patient doesn't have florid acute pulmonary edema, patient is stabilized after the initial stabilization of heart failure in your ICU, or Dr. Archan, if you're talking about a patient coming to your OPD with an EF of 20%, but he's not overtly in class 4, yes, you should add a beta blocker. Here, I'd like to stress again, beta blocker will have the maximal mortality benefit. So a heart rate of 70, 80, 90, patient is slightly tachycardic, beta blocker, but not plain metoprolol, but long-acting metoprolol. I prefer bisoprolol as the first drug of choice, or carvedilol. The patient has borderline pressures. Suppose the patient's pressure is 110/70 and you're scared to add high-dose beta blockers. There's a combination available in the market with carvedilol plus ivabradine that will help in heart rate reduction. Remember, your target heart rate has to be around 60 in these patients. The lower the heart rate, the lesser mortality for these patients. Yes, you should add beta blockers in these patients.
Actually, I think it is a very guideline recommended protocol for the treatment of heart failure. But as the MRAs, I still feel, Dr. Sandeep, that these are very under prescribed and under. We talk about, like, I mean, like, I feel that these drugs are still underutilized. What do you?
I think yes. So we've done a lot of study in heart failure, and only 30% of heart failure patients are getting GDMP. That's guideline-directed medical therapy. Okay. So it's being prescribed by only 30% of you and me. So I think we are to blame because we ourselves are not aggressive enough to follow guidelines. So yes, we should spread this message that those 4 pillars should be there in all our prescriptions now.
Okay.
So 30% is a very, very small number. We are giving SGLT2 inhibitors along with loop diuretic in heart failure.
Yes.
We have to take care more of it.
Yes, Dr. Archan. So loop diuretics has to be given, like I said, only in the acute decompensated phase. On a long-term basis, you can safely use dapagliflozin 10 mg once a day or empagliflozin 10 mg once a day on a long-term basis. So yes, because of both having a diuretic effect, you have to be careful about the fluid status of the patient and adjust the dose of the loop diuretic, not of the SGLT2 inhibitor. Dr. Archan, I hope that answered that.
Yeah, thanks.
Yeah.
Sir, sorry to interrupt, sir. Can you please turn on your video, sir?
Sure. Why not? There you go. All right. So aldosterone escape in CCF. There's this theoretical slide that they've mentioned here. Importance of the time of initiation of MRAs on the risk of mortality in patients with heart failure with reduced EF. So we all add beta blockers and ACE inhibitors up front. The point of emphasis here is MRAs should be added as soon as possible to offset. There's this tolerance kind of thing which happens so that the ACE inhibitor effects goes on for a longer time. So MRAs, like Dr. Hardeep had mentioned, should be on your prescription up front for the management of heart failure with reduced EF. So comparison. So this is the slide we've been all waiting for, and we are using more of spironolactone and as compared to eplerenone because of the financial factors. But improvement in systolic function has been seen more in the eplerenone group compared to spironolactone. Again, I emphasize, if there is a financial factor, stick to spironolactone. But if there's not, try and initiate eplerenone, especially with HEF-REF in your patients. So when you prefer using eplerenone and spironolactone, any specific patient profile, I would say just the financial factor profile. Any other inputs are most welcome here.
Actually, I feel when the patient who are more at risk of hyperkalemia, there also we should be very careful that eplerenone should be used, because in many studies it has been seen that the hyperkalemia was, incidence was much more, 10% as compared to eplerenone, where it was only 1.5%.
Yes,
so
yes.
also needs to be taken into account. So that is one. And then patient with chronic liver disease, there the chances of gynecomastia will be there, breast pain, and also in some cases impotence has also been seen. So we have to be very careful in these patients. And then the cost is always there. And then in female patients also, because the spironolactone, I feel, Dr. Sandeep, you must be knowing better, because this is 40 times more potent and
Yes, it is.
specific medication. So the interaction with the progesterone and testosterone hormone is much less as compared to spironolactone. So in young female patients in reproductive age group, there also we have to be very careful, I suppose.
Right, and eplerenone is more specific for the receptor. So yes, lesser side effects, like Dr. Archan had mentioned initially, lesser side effect profile, more safety, more efficacy. Point well taken, Dr. Mohanjit. All right. So spironolactone and eplerenone dose adjustment proposal. So we're all scared of the risk of hyperkalemia. I'm gonna summarize this slide very briefly here. So yes, less than 4, do not worry, but up titrate the dose of both the drugs. Between 4 and 5.4, that's where our most potassiums are. Do not adjust the dose. Do not raise the dose of either of the drugs. Between 5.5 and 5.9, yes, where we raise our alarm. Again, remember, between 5.5 and 5.9, you do not need to stop the drug. You can decrease the dose of both drugs by 25 mg. If they are both on 25 mg, you can make it alternate day, but you will not need to stop the drug when patients are on spironolactone. But if this happens with eplerenone, you can stop it for 5 days and reassess. So between 5.5 to 5.9, we have to be cautious, but do not worry. But if it's more than 6, you have to stop the MRA treatment. So one point here, the patient will also be on an ACE inhibitor or an ARNI like Azmada, Vimada. So what will be your treatment profile here? What will be your treatment protocol? If somebody comes to you with a patient being on valsartan plus spironolactone, will you stop both drugs when the potassium is 5.9, or will you stop one drug? I'll open this question to the house.
I think we should first stop one drug and then monitor potassium level.
So which drug would you like to stop first, ma'am?
I think if the patient is on spironolactone, then I will, withhold that one first. Sure, excellent. And that's the right answer, Dr. Mohanjit. So if the patient is on spironolactone or eplerenone and the patient is on ARNI along with these drugs, ARNI, that's sacubitril valsartan, is known to cause severe hyperkalemia in a very small percentage of patients. But obviously, when given both together, the incidence rises. So stop these drugs first, spironolactone or eplerenone, whatever the patient is on, and do not stop both drugs, because you will offset the mortality benefit right away. So you can correct the potassium, and then you can start reinitiating the drug in a lower dose on follow-up. If the patient's potassium continues to be high, even on ARNI alone, then you will have to think of stopping or replacing that drug. But again, if you're thinking of a patient is on ARNI and the patient gets hyperkalemia, don't think to change him over to enalapril or plain valsartan. Always remember that ARNI has lesser incidence of hyperkalemia compared to ACE inhibitor or ARB alone, because of the presence of neprilysin inhibitor in that combination. So what is the preferred dose and how is the dose titration carried on in your practice? We all use 25 mg once a day. We all know that. In your experience, do you people, all my colleagues, do you go up to higher doses in your practice, or do you stick to 25 mg? I mostly stick to 25 mg, very rarely go higher. But what is your experience?
I usually go up to 50 mg.
For both or for either?
Spironolactone.
For spironolactone. Okay. Dr. Harpreet?
Sir, I think I also go up to 50.
Okay, right. And Dr. Hardeep Singh, please.
So maximum dose of 50.
50. Has anybody got experience with 100 mg of eplerenone so far? No.
No.
Okay. Dr. Vinay?
I even also go to 50. I think it's a protocol, but we have been taught from us these days.
Sure, fair enough.
Yes.
So yes, and I would agree there. Our maximal dose for spironolactone has to be 50, and that's the combination available with the Ditor Plus anyway. So we can safely go up to 50 mg in all our patients.
Sir, I have a question regarding the
Yes.
frequency of potassium monitoring in such patients who present in OPD.
Yes, please.
What should be the frequency of potassium monitoring in such patients?
So I think you mentioned earlier. Yes, you mentioned earlier 7 days, 2 weeks, every month, and every 3 months. That is what I follow as well, and that is how you should do it. Initially, when you initiate treatment, get a baseline done, get a potassium done 1 week later, a month later, and then every 3 months.
I want to ask.
Yes, Dr. Archon, please.
I think we need to tell the patient regarding the that has to be taken.
Sorry, Dr. Monjit, what are you mentioning, please?
Diet recommendation.
Diet recommendations, yeah. So avoiding hyperkalemia. Excellent point taken there. Dr. Archon, you had a question there, please?
In few prescription I have seen from some other hospitals, they prescribe loop diuretics oral potassium.
Sorry, loop diuretics?
Plus oral potassium.
Right.
So,
yes. So when you
advisable to use such combination, or we should go for like combination of loop diuretic and MRAs?
So yes, the old teaching was, even when we were doing our MD, was loop diuretics plus oral potassium. But now, yes, you should be using MRAs plus loop diuretics. That will offset the effect of hypokalemia, which is coming with loop diuretics. So yes, the latter point of your statement, loop diuretics plus MRAs are the preferred combination to offset both effect of hyper and hypo from both these drugs.
That is why Ditor Plus plays a role.
Yes, it plays a role. And a lot of companies have come in. Even the Eplerenone, a lot of companies have come in with a combination. Cipla is there, Lupin is there with a combination of Ditor E now, which is Eplerenone plus torsemide. So if you look at this slide, the prevalence of hyperkalemia was 9.3%, out of which 54% was truly related to. So just a 4% incidence of hyperkalemia in these patients. So it's not just MRAs, but other drugs being used as a combination, which are causing MRA-related hyperkalemia. And Dr. Mohajid's point is very, very correct, that we should educate the patient about potassium levels in diet as well. So what percentage of heart failure patients on MRAs develop hyperkalemia in your practice, and what is your protocol? I'll open this to the house again, please. So we've seen the standard how we should manage, but in our practice, and when we are routinely checking it, I would say in my practice, I would start the answer with mine. I get this problem in around 5 to 10% of my patients on a combination of ARNI and MRAs. Dr. Harpreet, your experience, please.
Sir, I think not very much.
Right.
Same, I think 5 to 10%, not more than that. Because mostly if the patients who come with grade 3 or grade 4 NYHA, they are already on a loop diuretic plus an MRA. So the hypokalemia problem is very less.
Right.
Until unless if we go on to the patient's diet and all that, then definitely very less patients I have seen who have come with hyperkalemia if they are on a combination.
Right.
But if they are a patient who is on an ACE inhibitor or an ARB plus an MRA, and we have not initiated any loop diuretic as of now, the incidence is little higher.
Right, fair enough.
We have to take into account whether the patient is on concomitant use of AS and ARBs also.
Yes, for sure.
Cure of, and in those patients, like, we can be more careful, and also with borderline, the kidney, renal
creatinine levels,
and EFR. So in those patients, we can be little more careful.
Right. Dr. Vinay, your experience, please.
So I have mostly used this combination with the loop diuretic because I have this stressful condition for me as well as for the patient, but they're seeing a hyperkalemia in the reports and worrying this. So mostly I have preferred only the combination itself. So my patients usually don't come to me with hyperkalemias. In fact, I would say 1 or 2% maybe. I've stopped somewhere this thing.
Right. So our suggestion here at this point should be, point well taken, Dr. Vinay, but our suggestion is in heart failure, we should limit the use of loop diuretics in the long run and rather up-titrate the dose of the other drugs. So when you're adding a loop diuretic, the pressures will go borderline. If you stop the loop diuretic, you'll be able to up-titrate the beta blockers more, the ARBs more. You'll be able to add dapagliflozin or EMPA. So that will help in mortality benefit of our patients as well. So, but point well taken about electrolyte imbalance. But I think if we limit the use of the loop diuretics, we can up-titrate the guideline-directed medical therapy much more in our patients.
Actually, there is.
Dr. Mohanjit, please.
There is another thing. See, Doctor, I think my experts, they will agree with me. Like in patients who come to us with liver disease and cirrhosis, we go up to 200 milligram of aldactone in such patients.
Yes.
And we don't fear hyperkalemia in those patients, even with 200 milligram dose of aldactone.
Sure.
But here in cardiac patients, there are, I mean, so many other things are happening in such patients, and at the molecular level and biochemical level. So I mean, they are, we as a clinical physician are a little scared while using higher doses of.
Sure. I think, yeah, point taken there, ma'am. And basically, and again, because we're using ACE inhibitors or ARNIs along with these drugs as well in most of our patients.
Yes. Once we are, I have started using this ARNI, and I've gained more confidence in treating those patients because they have wonderful results.
Yes, they are. Yes, absolutely, absolutely. Totally agree there. And in ARNI as well, we should try and go to the maximal tolerated dose to 200 BD. We are scared to go up on higher doses, but remember 200 BD gives marvelous results in heart failure. I've seen patients' ejection fraction improving in my experience as well from 20% to 40-45%. Loads of patients having mortality benefit. Remember, heart failure is a downhill disease. So the EF will definitely reduce with time. So a patient might say, sir, abhi bhi 25% hai, piछle saal bhi 25% tha. That is a victory for you. If you keep the EF at 25%, even for 2-3 years, that's a victory of a new drug that you're giving.
Are there any studies to document these findings? That
Absolutely. It has been shown in a lot of trials. The Paradigm HF trial being the biggest trial for ARNI, it has shown a significant improvement in heart failure. This trial was stopped within 9 months of initiation because of significant mortality benefit.
That is true. Paradigm, I agree. But MRAs, Dr. Sandeep, any trial?
Ephesus trial has shown. Ephesus trial has shown the most mortality benefit with eplerenone. For sure, that has been documented, and that's why it's a class 1 recommendation for heart failure with reduced EF. We're not talking about HFpEF here, but HFrEF.
So these MRAs also increase the uptake of norepinephrine by cardiac muscles, I think. So increase the contractility.
I'm not sure of the cardiac physiology here. I'll have to read that up and get back to you, Dr. Archit.
I have read somewhere.
Okay, all right. Sure. All right, so timing of eplerenone initiation and outcomes in patients with heart failure. So this is the Ephesus trial we were talking about, ma'am, Dr. Mohanjit, ma'am. Early administration of eplerenone improved outcomes in patients with LV systolic dysfunction and heart failure post-MI. 31% reduction in all-cause mortality if initiated within like 7 days after the event compared to if it's initiated later on. So significant mortality benefit. So how early are MRAs initiated? And Dr. Vinay and Dr. Hardeep said that upfront in your first prescription, MRAs are initiated in most of our prescriptions, and I'm sure everybody agrees here. Any different thoughts on early initiation?
Similarly, like beta blockers also we prefer it should be started as soon as possible.
Yes. So I'll tell you my protocol. If a patient comes with acute decompensated heart failure today, suppose, I will start him on IV Lasix 28 hourly or Lasix infusion. I will add spironolactone 25 OD right away or eplerenone 25 OD right away. Just checking the baseline creatinine potassium. I will add beta blocker the next day, within a day after stabilization. I would add ARNI 3 days, that's 1 day before discharge. And then dapagliflozin or EMPA within 2-3 weeks. So the MRAs and beta blockers should be upfront in my guide, not my guideline, what I follow. And then you can add EMPA or ARNI. That's your personal choice. My personal choice is ARNI because ARNI has been time and tested, proven over the last 4-5 years. EMPA and DAPA have just come in, but all 4 should come on your prescription within 1 month. But remember, I added ARNI plus DAPA in one patient together. And that is one lady, I remember, she went into acute renal failure. Luckily, she recovered after I stopped both the drugs, but her creatinine shot up to 3.5. And it is a caution to start both together. So this is management of patients with HFrEF, ACE inhibitors or ARNI, beta blockers. Remember, just those 3 beta blockers. Don't add nebivolol. MRAs, we have those 2 MRAs. DAPA and EMPA. EMPA dose, we are aware of 25 mg as well, but the dose recommended for HFrEF is 10 mg. DAPA also has 10 mg. Loop diuretics for fluid retention, and then you can do device therapy if the QRS is wide. You add ivabradine if the patient is in sinus rhythm and the rate of more than 70. Don't add ivabradine upfront. Always start with a beta blocker first. If the patient doesn't tolerate a beta blocker, or you cannot up titrate the beta blocker, then go on to Ivabrad. Ivabrad is not a replacement for beta blockers. So at what stage diuretics and MRAs both are needed? Now, Dr. Harpreet, ma'am.
Sir, I think we've already discussed this, that if a patient lands up in the emergency, I think the first preference would be these, the diuretics, as well as after 2 or 3 days an MRA. In grade 3 or grade 4 NYHA, I would prefer a combination.
Perfect. Any other thoughts here, Dr. Hardeep Singh, please?
I agree with Dr. Harpreet what she had said. I think we should plan to take them.
Right. Dr. Atul, would like to give an input, sir? Dr. Atul Gupta, please. Dr. Atul, there with us?
The preferred choice.
Preferred choice. Okay, Dr. Mohanjit, you can go to the second question. What is the preferred choice? Right, ma'am.
If the situation permits me, then eplerenone and torsemide.
Absolutely, I would agree there. Preferred choice of therapies. If you are using for decongestion as well, if using alone, I would prefer eplerenone alone, like you said earlier, because of better mortality benefit, better safety profile. But if cost is a factor, then spironolactone, looking at potassium levels, gynecomastia, and other side effect profile.
Sir,
right,
I have one question. Sir,
yes,
I have
Dr. Harpreet. Yes,
so
please.
if a person who has been started on a combination of diuretic as well as an MRA,
yes, please.
Do we need to de-escalate it, or what I can say, stop a loop diuretic if a patient comes on a follow-up in an OPD?
Yes,
or
yes, absolutely.
If a patient is doing very fine with a combination of Ditor plus, you can say 10 by 25.
Sure.
Right?
And so that's the point I'd like to stress here.
Do we need to stop the diuretic, or we can continue that if a patient is totally fine with it?
Sure. So the patient being totally fine, like I said earlier, is your symptom profile being totally fine.
Yeah, exactly.
I would definitely, I would definitely stop the loop diuretic. Like I said earlier, I would up titrate the other drugs. You up titrate the ARNI, the beta blocker, because even 10 mg of torsemide will cause some hypotension. Some fluid imbalance, so some dehydration. So take off the loop diuretic for sure. You give a prescription of Ditor 20 mg, one strip, ask the patient to keep it with himself. For any acute onset symptoms, he can take it on an SOS basis for mild breathlessness. But take it off your regular prescription. I would rather have eplerenone of 50 or a spironolactone of 50 OD rather than a Ditor plus. Or I would rather have, on a follow. I would rather have carvedilol 12.5 BD rather than 6.25 BD. If that's the cost I want to pay for taking off the Ditor completely. Definitely take off the loop diuretic completely.
So is there any study that suggests that if we use loop diuretics for a long time in heart failure patients?
Yes. So all these studies have shown for heart failure that loop. So on the other hand, I would rephrase that question, Dr. Archan. It has been shown that loop diuretics do not have any mortality benefit. They just have a symptom benefit or a morbidity benefit. So instead of that, it is recommended to go higher on the drugs which are having a mortality benefit. So higher the dose of ARNI, the more the mortality benefit. So higher the dose of carvedilol. I would say I respect. There's a lot of senior cardiologists in town, 2, 3, the most senior people in town. I will not name them here, and they have excellent prescriptions here. So they use carvedilol 25 BD. Which is unheard of in our generation or the next generation. So, I mean, those are things that we need to follow. So, I mean, again, I will not name them. Very senior people of Hero Heart and CMC are using carvedilol 25 VD, and that is something we need to follow. Don't use torsemide on a long-term basis. There is no detrimental effect. So I'm not saying there is a side effect, but it is impeding you from using what is helping the patient more.
Long-term use, even they increase the mortality or some morbidity?
No, they are not. No, again, you're getting my answer wrong, Dr. Arjun. I'm saying that they are not increasing the mortality, but they are not decreasing further. So if you take them off, you will, because of taking them off, you will be able to increase, because only when you take them off, you will be able to increase the dose of the other drugs, because these drugs also have an effect on your blood pressure and your renal function. That's what I'm saying.
Thank you.
Thank you.
So one more question, please.
Yes,
So
yes,
in the case of the SGLT2 inhibitors,
yes, please.
there are side effects which we have seen
Yes.
so very less about the
Yes.
UTI part.
Yes, yes.
So is there any space, like if we don't want to use an SGLT2 in a
Yes.
patient who has come with heart failure,
Sure.
and only want to concentrate on the 3 drugs like an MRA, ARNI,
Sure.
ARB,
Fair
and
enough.
a beta blocker?
Fair enough.
Can we use that also?
Yes, absolutely. If there's a side effect profile which is not acceptable to the patient, recurrent UTIs, which is harming the patient more, you will have to take them off. We have no choice. I agree with that.
Because in that SGLT2, I have been using more in patients who come with diabetes.
Sure.
My experience more is in those patients who are diabetics.
Sure.
And or those who are pre-diabetics, but they are obese and require a weight reduction, or what we can say is an HbA1c of 7 with the body weight of around 100.
I
so
agree.
in that patient, I think I would prefer an SGLT2. But a patient who's a non-diabetic heart failure patient, thin, lean patient, because SGLT2 definitely would cause weight loss.
Sure.
So in such patients, a patient who is very thin and lean, just 45 kgs, I would never prefer to use an SGLT2 if HbA1c is just 4 or HbA1c is just 5.
Sure.
In that patient, I think three drug combination, the ARNI, ARBs, beta blockers, and MRA would be my choice.
Point well taken. Point well taken. But remember that in these patients, if the patient is coming in cardiac failure, that means even with the weight of 45, if he is in fluid overload despite his low weight, then I mean, they will have a mortality benefit.
Yes. Then so obviously if we have to use it, but in a patient who is just in grade 2 NYHA and a very little pedal edema, I think I would not prefer using an SGLT2 if he's a thin, lean patient.
Sure.
And a
non-diabetic. I would respect that. It's a clinical decision. You have much more experience in diabetes than me. But because of heart failure, in heart failure patients, we have started using it. But yes, we have to be careful about
because the indications of heart failure of SGLT2 in heart failure, irrespective of diabetics, have come just recently.
Yes.
But in diabetics, they have been studied more.
Yes,
the EMPA and the dapagliflozin.
Yes, for sure.
They've been studied more in diabetes as compared to the patients who have just heart failure and no diabetes at all. The studies are limited, I guess.
Yes, with no diabetes, DAPA-HF trial has shown that. So these are very landmark trials, the EMPA-REG outcome and the DAPA-HF trial, which have shown.
EMPA-REG trial had patients who had diabetes also.
Yes,
there were patients who had diabetes included in it. So EMPA-REG trial was one of the major trials for SGLT2 in diabetic patients.
Yes, so
it did not include non-diabetic patients who had heart failure.
Fair enough. So that was the Emperor reduced trial, which has come recently.
Exactly.
So that is the Emperor reduced trial, and this is shown unequal. So it has shown marked benefit for HFrEF, irrespective of the presence or absence of diabetes. So both drugs are now a new pillar. Again, it is a clinical decision. It is our discretion, but we should keep that in mind for sure.
Hypoglycemia will also occur, no? If we use SGLT2, that would be a side effect. A little bit of hypoglycemia would occur.
So the trials have shown. So the trials have shown that no significant hypoglycemia, even in the absence of diabetes. So that's why they've come as recommendations for HFrEF. The trials have shown scientifically over the last 1 year, which have come out, no significant increase in symptoms of hypoglycemia. I can't explain that because
I normally get little scared using SGLT2 patients in non-diabetics.
And so are we.
Nucleosides, don't think they cause hypoglycemia because their mechanism of action is different. they act from the, like, they cause glycosuria.
Glycosuria, yes.
If the blood sugar levels are high, only then they will act. Otherwise, they will not increase any insulin
yes.
release in the
Exactly.
body.
That is one point which has to be taken into consideration. But still, there is little hesitation on my part using SGLT2s in patients just come with pure heart failure and no diabetes.
Yes.
But maybe
So
I'll have to overcome that hesitation.
No, totally agree, Dr. Harpreet. And so were we very apprehensive till 3 months ago, and we've started using that slowly and gradually. But we've got good results, and we explained to the patient कि ये हमने दवाई गलती से नहीं दी है, आपका chemist बोलेगा कि ये sugar की दवाई दे दी है. We explained that to them, and we're getting good results.
Because cost factor is very important, na, sir. In I think empagliflozin, they still have only I think Cipla is giving and the Boehringer is giving, and they're very costly. So if the patient is already on Vimada and we add on an SGLT2, and definitely DAPA has come up with lower price. But if we want to use Jardiance or if we want to use an Oberavo, but definitely cost factor would increase because Vimada itself is around 110 rupees per tablet. And patient has to take it twice a day. So cost factor is a very important thing if we are using both SGLT2s as well as ARNIs or ARBs. So I would more prefer going for an ARNI ARB than going for a SGLT2.
Fair enough.
Dr. Sandeep, just in 2021, the Emperor Preserve trial it has come. You know,
so HFpEF, yes. So HFpEF patients, empagliflozin is the only SGLT2 inhibitor which is showing a mortality benefit for HFpEF. But again, not very well accepted globally so far, especially not in India, because HFpEF, like we said, like Dr. Harpreet just mentioned, the cost is so high that I still myself am not, convinced to spend 50, 60 rupees per day of a single tablet in a disease where we can target the risk factors more than this. But for ref, I would definitely go all out with all those 4 drugs.
Definitely.
So last question, Dr. Mohanjit, you had mentioned liver disease, question 13. Any other indication apart from heart failure where MRAs are used? All 5 of you are more experienced than me in other diseases where you might use MRAs.
Hepatitis and liver disease we have already discussed. And I think another indication is in polycystic ovarian like hirsutism.
Exactly.
Okay.
In those cases also we are using spironolactone, and but these are the 2 definite indications. But Dr. Harpreet, I don't know as an individual or antihypertensive medication, what is the status of the,
alone aldactone as a single antihypertensive, normally what we used to study was that definitely you should add a little diuretic first when you detect a patient who is a hypertensive. But I think now those guidelines have changed. Those were when we used to study that a diuretic should be added first and then you should go on the other drugs. But now I think ARBs and ACE inhibitors have taken their place as first indication.
And they have a good role.
Aldactone, as of now, I have seen good results in patients in girls who come with hirsutism. It's a very good drug.
Also, it's a
use it if the patient tolerates it.
Okay, point I'd like to make here is regarding regarding the hypertension guidelines. So ARBs plus calcium channel blocker plus diuretics, we're all using as combinations. So these 3 drugs, like Dr. Harpreet mentioned, diuretics, but the diuretics they're mentioning there are thiazide or thiazide type diuretics. Those are the first line treatment. Spironolactone is only to be used for resistant hypertension. So once you are on the maximal dose of telmisartan, amlodipine, and hydrochlorothiazide, and the patient's pressure is not controlled, please add spironolactone or eplerenone 25 mg once a day, and you will see marvelous results before you go on to your prazosin or your other drugs.
Definitely.
Right,
and primary aldosteronism also it can be suffered. Although we don't clinically diagnose it, but we can drive the blood pressure is not controlled with routine drugs.
Sure.
Another thing, Dr. Sandeep, I don't know whether I am saying it correctly or not.
Yes,
see, the diabetes mellitus itself is considered to be a condition leading to hyporeninemic, hypoaldosteronic situation. I think if I am saying it rightly, so we have to take that part into account when we are using, MRAs in patients who have heart failure, and how will it change their clinical efficacy in such patients?
in patients with diabetes?
Diabetes.
I think so. So yes. So in patients, so the incidence of heart failure is anyway much higher in the diabetic population, even in the absence of coronary artery disease. And there also MRAs have been found to be equally or more efficacious. Even ARNIs have been found to be equally or more efficacious in terms of mortality benefit. Even again, absence of presence of diabetes, it has to be used.
Okay.
I think we can wrap up this very nice session today with such eminent physicians. Dr. Mohanjit, who helped me do my first lumbar puncture in my MD medicine days. Dr. Harpreet, a great colleague from Fortis. Dr. Archana, a great friend. Our daughters are also friends, and other eminent physicians in town. Thank you for being with us today. Thank you, Cipla, for this opportunity, for bringing us all together.
And Sandeep, it is so nice to see you doing so well. It seems as if जो आपके colleagues होते हैं, achievements साथ ही अपनी achievements.
Thank you very much.
Such a giving experience. No, I mean,
that's so kind of you. So kind of. Thank you very much.
Thank you, sir.
Thank you, Dr. Archan. Thank you.
So thank you very much, Sandeep, sir.
Thank you, Dr. Hardeep. Thank you, Dr. Vinay, Doctor. Thank you very much, Dr. Gupta. It was a pleasure indeed.
Thank you very much, Sandeep, sir, for giving us this precious time. And sir, with your permission, we will do such type of educational program in future also, sir.
Absolutely.
It was very nice and interactive session, sir.
Thank you. Look forward to it. Thank you. Thank you, everybody.
Thank you, sir.
Thank you.
Thank you very much, sir. Thanks very much from Cipla side, sir, all the delegates, and thank you, Sandeep, sir.
Thank you.
Thank you.